Well, good afternoon, everybody. I'm not sure where those birds are coming from, but it sounds like spring. Um, Thanks, everybody, for joining us today. It's 3 o'clock, so we're going to go ahead and get started. I think I know most of you, but for those of you who don't know me, Jay Byers, CEO of the Greater Des Moines Partnership. So first and foremost, thanks for making time to be part of this conversation today. And a special thank you to all the Greater Des Moines Partnership investors for all that you do to not only support us as an organization, but our community. We all know it's a tough time out there right now. And we know that there's a number of folks in small businesses in our community that are hurting right now. And we're dealing with a very serious situation on the healthcare front. But we also know that Greater Des Moines, DSM USA is a strong and resilient region. And I think we're showing that at a very tough time. And we thought this would be a really great opportunity to hear from the top experts in our region in terms of the healthcare system. And while the issue of overall healthcare and keeping everybody safe and healthy is a very important goal for all of us right now. And we also know that this current pandemic situation with COVID-19 has potential to have a very big impact on our regional healthcare system. And we've seen what's happened in other countries and other parts of our country. And so we thought it'd be very insightful and helpful to bring together our top experts to share with us their perspective on what's happening in our state and in our region, and maybe how we can best assist them and for what we might be able to expect in the upcoming weeks. And so I'm going to be turning it over to our presenters here shortly. What we'll do is hear from them, and then we'll have an opportunity for some Q&A at the end of this presentation. And through your chat boxes, if you want to submit questions, you can do so that way, and then I will moderate after the presentation. So without further ado, I'm going to kick it off to our presenters. But with us today, we have Bob Ritz and Dr. Kent Carr from Mercy One, and from Unity Point Health, we have Kevin Vermeer and Dr. Dave Williams. And so again, thank you so much for making time for us. Thank you for what you're doing for our community. We know it's a very, very busy time for you, but for you to carve that time out for all of us, we very much appreciate it. And just, we wanted to let you know how much we appreciate what you and your teams are doing right now on those front lines to keep our community safe and healthy. So without further ado, I'm going to turn it over to Bob Ritz, President and CEO of Mercy One. Thanks, Bob.
Bob, I think your phone might be muted.
I just want to see if anybody had any questions.
Oh, okay.
We just completed the brief presentation we had, and I thought I'd ask if there's any questions. In any event, let me start that over. I'm just glad that you're taping this to catch that. Jay, thanks. And thanks to all of you at the partnership, and I think just across Central Iowa, and certainly the investors of the partnership. We're delighted to spend time together on this topic. I can't think of anything that's been more unifying and at the same time intensifying than COVID-19. With me is Dr. Ken Carr, who is going to give a brief overview, kind of the clinical background. We've got just a few slides. Kevin and I drew straws, and I got the short one, but I know Dr. Williams and Kevin, all four of us, will join with you in open conversation. So without any further ado, I'm going to turn over to Dr. Carr and ask him to really just go through the first, that's actually slide 3, which is a description of COVID-19. I'm not going to go over today's conversation outline. It's pretty self-explanatory. So Dr. Carr?
Yeah, thank you. I don't know where Jay thought I was an expert, but I certainly have learned a lot about COVID-19 in the last month, and I'll just sort of introduce the subject.
We'll go to the next slide, please, Jay.
Okay. So, COVID-19, initially we were calling it the novel coronavirus. Coronavirus has been around for a long time. We've known about them actually in humans. It oftentimes causes a common cold. And through the years, there have been some mutations of coronaviruses that have caused some serious illnesses. In 2002, SARS, the severe acute respiratory syndrome, appeared, and we were able to keep it somewhat localized back then. And then MERS, which is the Middle East respiratory syndrome, came about in 2012. And actually, this outbreak is very similar to those, other than we're not able to contain it like we were those other outbreaks. Again, probably caused by a mutation in coronavirus that was in animals and then transferred over to humans. So this first was discovered in Wuhan, China, which is central China. The first cases were in November of 2019. That's not very long ago, to think about it. It was identified at the end of December. They found out what was causing this outbreak of pneumonias and respiratory failure in central China. So again, has moved very quickly. Just in very, very high level terms, that the virus has an incubation period of about 5 days. So after you're exposed, the slide says 2 to 12. So that's sort of the range, but usually it's around 5 days. The symptoms usually are fever, cough, muscle aches, some nausea, abdominal discomfort, and 80% of the folks, it's a mild flu-like illness, which is the good news. But in about 20%, it progresses, and the most common progression is to a respiratory illness and presents with shortness of breath, difficulty breathing, and that's in about 20% of folks. Probably about 15% ended up needing to be in the hospital, and about 5% go on to respiratory failure and need intubation and ventilatory support. But the other thing that's unusual about this virus is how quickly it's transmitted. Certainly all the evidence at this point is that it's transmitted by direct contact or by respiratory droplets. And I say respiratory droplets, coughing, sneezing, actually just talking. I'm putting out respiratory droplets right now, just talking to you. So Bob makes a face. And it spreads. The other thing that causes it to spread more quickly is because some folks are asymptomatic or a mild disease, they really don't know they have it. So they're not able to not spread it. It also tends to be fairly persistent, stays in the air. If I sneeze for 2 or 3 hours, it can stay on a surface like this table for a couple of days. Yeah, that's another reason that it has spread so much. The spread to transmission rate, which some people call the R naught, is about 3. So one person generally transmits to 3 additional folks, which is what causes the epidemic. So that's just a real quick overview.
Thanks, Ken. Okay, let's go ahead and go to the next page, please. And this is just kind of a profile of the country, but also on the left side, you can see the case counts and mortality rates. Let me remind you, actually today in Iowa, the case counts went up to 613. And the criteria by which people are being tested is a big factor in this. You essentially have to be symptomatic, which means you have to be shown some of the symptoms that people believe are prone to this conclusion that you have this COVID-19, and therefore you qualify to be tested. So inherently, we have a much higher rate of kind of the admissions to the positive case scores. We're starting to get more testing done in Iowa. We're starting to get a bigger negative rate, which is good. But you can see that the United States, with 210 cases as of yesterday, clearly the largest outbreak in the world at this point. And to the right is the Johns Hopkins map. You've seen this before, and this shows you the density of infection. And that's an important map. There's a new map that came out today that looks at cell phone transmission and people staying put, meaning social distancing. And Iowa on that map actually looks fairly well. One of the states on that map that looks the best, ironically, and somewhat paradoxically, is New York State. And that's because the map is new. And people, I think, are absolutely petrified of contact and getting this virus, so they're staying in place. The next slide is a slide that we prepared internally. It just shows the case positive cases by date. And the green line are the actual per day. Our first case was in the 9th of March. And you can see now, and today, the addition will be up to 613. The slope of this line becomes very important, and there are two lines on the chart. The dotted line is what we would call the linear growth line. It is the expected progression based on the trend before it. The green line, the actual case line, when it gets to that left of that line, shows a trajectory slightly more than the dotted line, which means instead of being linear growth, we run the risk of being into exponential growth. This is the type of a chart that an infectious disease physician or an epidemiologist or somebody in policy, public health would look at and say, we need to take action. And this is precisely the kind of slope that we want to take away. We want to flatten this slope. And the reason for that, if you go to the next slide, well, the next slide is a little bit more about Iowa. You can just see that we're pocketed really in three counties where the dominance of the positive cases have been found: Polk, Lynn, and Johnson. And Lynn actually has the largest case count. And to the right of that, you have by age and gender cohort. And what this shows is 67% of all cases are actually 60 years or younger. And that's a good thing because that population has a much higher chance of positive recovery and return to normalcy. Whereas in the older population with underlying risk factors, the mortality rate goes up. To the right of it, you see both the male and the female breakdown, and it's slightly more female in Iowa at this point. That obviously is subject to change with a higher population of cases being tested. The next slide gets into the public health debate and dilemma and what we in the healthcare industry are going through. And let me just say, first of all, that when the government 2 weeks ago, asked us to suspend what we call elective health services, we essentially turned off about 50% of our healthcare delivery system between Kevin and UniPoint and Mercy One and all the other health systems in the country. And what that means is we wanted to create capacity in the system to deal with what you see on the left slope of this chart. And that is, from a public health perspective, with a virus with little knowledge about it and a transmission of 3 times, if there's nothing done on this thing, it goes freely. And the next thing you know, the infection rate is very high, the hospitalization rate is very high, and unfortunately, the mortality rate equally could go high. Mitigation is really what we call general mitigation that you would have if there was an outbreak of a flu or measles or something to that fact. The hammer strategy, and I'll reference this paper in a moment, is when states, policymakers, federal policymakers put the hammer down and say, this is what we're doing. And the dance is after the virus, the pandemic is actually on the downside. And it's how do we keep it from reoccurring? So if you go to the next slide, you'll see why these discussions about social isolation and closing businesses and schools and the debate about other forms of reducing contact become prominent. The red line at the bottom is the capacity of our healthcare system per 100,000 people for critical care beds. Every curved slope above that, every dot point above that is excess to the capacity of our existing system. And so the do nothing, if you follow that chart, the do nothing would absolutely wreck the American healthcare system. And maybe some people would like that. The problem is that means more people likely would perish with this disease because they can't get the treatment they need. And if you think about what's going on in New York City, and in no way would I classify the images of New York City, the reality of New York City, and those slopes upwards to 250 critical care beds per 100,000 population as being the same scenario. But the point is, it's well above the red line in New York City. And you can see how the healthcare system can't respond efficiently and effectively. So from a policy perspective, when we closed down our elective care services at the request of the government, Kevin, myself, all of our teams across this country, we converted our acute care delivery system to serve much more in a public health system platform. And the goal of that is to bring the curve down, at the same time, build more capacity in the system should it be needed. If you go to the next slide, it's just an indication of how we're approaching this. Both Mercy One and Unity Point have adopted the FEMA Central Command structure to manage our various markets throughout the state, to make sure we have a consistent approach to trying to bend the curve down, and at the same time making sure that our capacity to respond to a higher level of infection in the population is moving concurrently, so that that red line in Iowa is in balance. The next slide shows Unity Point's command center as well. Our goal is to reduce the number of people who are infected, to reduce the number of people who are hospitalized, reduce the number of people who need ventilation or oxygen therapy, and certainly to reduce the number of people who suffer the loss of life. And furthermore, our goal is to return our communities to a normal life. We want to protect our community to the best of our ability, and we want to protect our colleagues and our physicians and all of our providers on the front line battling this as best we can. So Jay, that's a brief overview of what COVID-19 looks like from the inside of both Unity Point Health and Mercy One, and I would suspect many health systems across the state and the country. And I'll turn it over to Kevin and Dr. Williams to see what they want to add, and then we can go into open discussion. I would ask you to turn to the last slide, Leah, or whoever's running this, because I think the slide beyond that, if you will, this is the most important slide. These are the people that are on in this care delivery system across the country who are bringing us a sense of confidence that we've got this. But by working together as a community, the probability of us succeeding is far greater. So with that, again, I'll turn it over to Kevin and Dr. Williams, and then give it back to you, Jay, to moderate.
Yeah, thanks very much, Bob. Appreciate it, and great job on really setting that framework. I think just a couple of things I would just add. So we're used to, Mercy One and Unity Point Health, we're used to setting up incident command sort of structures to deal with various levels of disasters or emergencies. The difference with this one is, typically what we're dealing with is we've got a flood, or we've got a tornado, or we've got really a relatively short-term event that we are looking to deal with. This event is not a short-term event. So, this, for us, and I'm sure similar to Bob, we've been in this incident command for now just over a month, and each of our individual hospitals has their own incident command structures that have also been in place now for a month. And, this is going to go on for a while. So it's really helping our people deal with the emotional support and the physical support to deal with the just the fatigue that comes with an event like this. And like Bob said, it's eerie because we've cleaned out our hospitals. So we've created a lot of capacity. They're half full or less than half full. And we're just sitting now planning, preparing, cross-training staff, and ensuring that, at the time that the surge does come, that, we are prepared and we are ready to handle whatever comes at us. The other thing I would just add is I think that, in the Des Moines area, Polk County, and certainly throughout the state, one of the benefits that we do have in this state is the collaboration between the systems is outstanding. We compete every day, just like others, but we are very good at collaborating, and I would say that the collaboration between the organizations has been outstanding. We are preparing for community sort of events together, and making sure that the community has the capacity and the staffing resources it needs to handle it as we go forward. Dr. Dave Williams is the CEO of Unity Point Clinic. He's also on Incident Command this week as a commander for Incident Command at the system level. So I just invite any comments that you'd like to make, Dave, and then we'll just open it up.
Yeah, thank you, Kevin and all. I think it's very well said by Bob, Kevin, and Dr. Carr. I think one of the common questions that I've gotten the last 2 weeks is, without hospitals full of COVID-19 patients, without clinics full of COVID-19 patients, what actually are we doing to prepare? And I think you've seen that a lot in the Des Moines community, not only in our hospitals where maybe you had a colonoscopy scheduled or a cardiac procedure or anything that was deemed really not a time-sensitive medical procedure that's been canceled, our best and brightest nurses and physicians. We're going to need as many masks and gloves and gowns. We're going to need as many operating rooms and beds as we can get. And you've even seen it on the ambulatory and clinic side. You've seen both systems really reconfigure their clinics. You've seen an incredible expansion of telehealth. And I think if that is not well known by people on this call and people that you work with, I would love it if you'd spread the word. You know, we could now get patients in on the telephone. We can see them in telehealth for both an urgent situation or routine care. Both systems are doing whatever we can to keep you in your homes and keep you safe, but still provide that necessary medical care. I think the last thing I wanted to say, and Kevin is spot on, you know, I've worked as a doc in this community for 20 years. There has always been great collegiality, support, and interaction between physicians in the Mercy field, in the Unity Point field, in the Iowa Clinic field, at Broadbonds. As a medical community, we've always come together. We will continue to come together. I don't care if you have run up the Mercy flag, run up the Unity Point flag. The way I believe all of us need to act is whoever signs your paycheck as an employer doesn't matter. We're all going to come together and work together to get through this crisis.
Great. Thanks, Dave.
So I think we're going to move into some Q&A right now. Now is the time. I know that a lot of folks have questions out there. So I encourage you to go to the chat and type in your questions here, and we'll go through these. The first one is from Michelle Book. And the question is our hospital system in Polk County overwhelmed today?
Kevin, you want to answer that one?
Yeah, I'd be happy to, or have Dave. I mean, I think we're both tracking activity very closely. And I would say today we are not overwhelmed. I mean, we've got a lot of capacity that we freed up. And like Dave said, a lot of the work that we're doing now and we've been doing over the last few weeks is planning. How do we create even more capacity when the surge comes? So, you know, we're converting spaces to additional ICU beds. I know Mercy is doing the same thing, converting other spaces into additional ED capacity. And so right now we've got a lot of capacity, and we're willing and able to take on whatever comes.
Yeah, we have real-time updates in the command center, and we can look at capacity in every one of our facilities and every one of our floors. We can break them down to who's in the ICU, who's in a surgical bed, who's in a medical bed. At this point, because both Mercy and Unity Point did the right thing and cleared those hospitals out, in almost every case, our capacity is well below the 80th percentile. So we do have room for patients in all of our facilities.
Hey, Jay, if I can add to that.
Sure.
You know, it's as a member of the Des Moines partnership, we're both a healthcare delivery system, but we actually are a business too. And to the point referenced earlier about when this federal government asked us to eliminate our non-elective services, I think it's important for everyone to understand that we eliminated about half of our revenue overnight. And as a result, there is an economic devastation of this to the healthcare delivery system all across the country. Mm-hmm. Thus, the need for the stimulus bill that was passed last week, the CARES Act, thank God for our senators and representatives, $100 billion in that act to help fund the loss of revenue and the increased cost of preparation for COVID. At this point, you know, we're not sure how that's going to get allocated, but the healthcare system in this community and in the state and in the country is an important part of the economic fabric of how the economy works. And so we've got about half of our healthcare system right now functioning, and again, the other half serving in this public health service platform in building capacity and ready mode. And it's important we're all aware of that. So this is not a business that's flourishing on the breakout of a virus. To the contrary, we project to lose hundreds of millions of dollars in the next 3 months each as a result of repivoting our organization's assets.
Very informative. Bob, thanks for sharing that too. I think people need to know that, so thank you for that. Next question is, Are you getting good data from models on what we should expect in Iowa?
Dr. Carr, you want to take that?
Yeah, you've been doing more of the modeling than I have, so.
I think the data for modeling, I'll start so that I finish the last one and then turn it to Kevin and Dr. Williams. We're getting the data we're getting. And until we get more testing, we're not going to have what we would think is enough data to really understand what the potential of this is. Here's the issue. These models that you see, there's too much information out there, first of all. And secondly, a little information can be dangerous unless there's a lot of knowledge to follow it. And let me tell you that the data, the way that it works is it's all based on infection rate in the population. And from there, everything flows. So you get your infection rate in the population, and then they're going to give you some standards on, okay, here's what you should expect about hospitalization from that global number. And then from that, here's the number of needed critical care beds. And from that, here's the number of needed ventilators. And next thing you know, you've got a model. And then you've got, okay, how many providers in the community divided by equal number? You say, okay, we got plenty of capacity. That's fine. So the model that you hear referenced a lot at the state, and by the way, the governor does these daily updates, and I think it's really important, and the leadership is critical on this. But these models are models that change significantly with a little change in data. I call to your attention the Washington University model people keep citing. 2 nights ago, I looked at that model from my home, and I was studying the results of the projection, and it said we would have enough medical surge beds, we would need 108 more intensive care unit beds, and that we had enough ventilators, and essentially the peak would be in April 18th. Last night, same time, same place, I looked at the same model. It said we were going to be short med surge beds by 11. We were going to be short critical care beds by 450, and we were going to be short on the ventilators. That the surge date, the peak date would be April 30th, and twice as many people would die than predicted 24 hours before. All based on the number of positive cases in that 24 period and number of tests being done. So my point is, the data that we're getting is directional. It is certainly not going to be precise, and the key for us is to monitor the daily positive rates and the hospitalizations from that versus our capacity and our ability to surge that capacity.
Very informative. Thanks, Bob, for that very much. The next question comes from Mike Hellick with US Bank. And what about the status of PPE here for healthcare frontline staff?
Kevin's turn.
Yeah, so PPE is something that, we are watching extremely closely. Certainly I'll make a few comments and I'll turn it over to my clinical colleague, because PPE is kind of a two-pronged issue. It's a scientific issue of what PPE is being recommended by the CDC and the WHO, and then it's just emotion and fear. And so you're trying to deal with really both sets of issues. Today, we are good on PPE. We are monitoring PPE really closely, and certainly, PPE preservation was one of the big reasons to, eliminate elective procedures to try to preserve the type of PPE necessary. That being said, it fluctuates, day to day, and so, we may be great in some areas of PPE on one day, and then we're looking for, outside sources to try to make, surgical gowns or other sorts of equipment on another day. So that's something we'll have to, and we do continue to watch closely, but certainly any comments Dave wants to make.
Yeah, I think Kevin hit the highlight, which is it's not just science, it's emotion, and it is highly charged in my field, clinical caregivers on the front lines. We monitor it all the time. I have a team of the best and brightest. I have 5 physicians who literally every day look at the newest guidelines. And remember, this is a brand new disease, so there's not a lot of established evidence. Things change literally daily about what procedures in the hospital require certain type of masks, what procedures in the hospital would require things that we do normally, like regular surgical masks, regular gowning and gloving. We've got to try to conserve that PPE to the best of our ability. So when the surge hits, we have it, and we have it where we need it. We also need to be able to track exactly which institution has that PPE. So if we have a shortage in the community, we can transfer and help each other out the best we're able to.
The other thing I would just add is, for many of us, this is not professional, it's personal. And so and I know the same at Mercy, our number one goal is to keep our caregivers safe. And we are going to follow the science. We're going to do everything we can to do that. I have a pregnant daughter-in-law, direct caregiver, tested positive for COVID on Monday. Keeping caregivers safe is by far our number one priority.
Very good information, and thanks for sharing that. And again, I think it highlights what you guys are all dealing with right now. So thanks for that. Next question is more of a big picture policy question. So with the increased use of telehealth, will that change how healthcare is delivered after this is all over?
I'll be glad to start with that. I think it will, and we welcome those changes. We've been trying to get telehealth going for some time, and I think it'll give caregivers an experience of what it's like. It'll give patients an opportunity to try it out, and quite frankly, I think it's going to change the way we practice medicine in the future. I think there are going to be several changes, and telehealth and telemedicine will be one of those changes that happens with this pandemic.
Yeah, I couldn't agree more. If there's a silver lining in this entire situation, telehealth might be it. And you're going to experience medicine actually, well, I'd say we're probably moving into the 2000s, not the 2020s, but every one of your industries has experienced just real transition because of telehealth. In medicine, I think we've wrongly held ourselves out as unique, and we're not. I think we need to be more consumer-oriented and really deliver care where people want it. And where that is, as best as possible, is if things can be done outside of a hospital, they're going to be done outside of a hospital. If things can be done digitally, they're going to be done digitally. And I do not see that going back to normal after COVID-19 is under control.
Very, very interesting. I think with what everybody's dealing with right now, when we deal with a situation like this, it brings out innovation and creativity in everybody, and we need to figure out those lessons learned that can help us improve everything moving forward. So that was a really great question and great answer. Next question, this one is going to be for the docs. Once a person is infected, how long are they typically contagious, and how does someone know when they can stop isolating?
Dr. Carr, you want that one, or you want me to take it?
Go ahead.
So, and remember, Dr. Carr brought this up to start with, remember, you can have this disease and not even show symptoms and not even know you're contagious. So I don't want people on this phone to just get a false sense of security if they don't have a fever or they don't have bad respiratory symptoms. But once those symptoms persist, or if you're tested COVID positive, you're really contagious for the longer of 7 days, or when you're completely symptom-free with no fever for greater than 72 hours.
And that's a good answer. And I think we're also learning a lot as time goes along. We're finding that some folks can still transmit the virus or even longer than that time, but that's generally considered sort of when you're not contagious. So we're still learning as time goes along, and we have limited testing capabilities.
Jay, just relative to that, and everybody knows the last thing you want me to be is a physician. However, we can't overlook the fact that this is a virus, and viruses live on. What we really need is therapeutic solutions and vaccines. And that I don't know that we're going to have the comfort level people are looking for, and maybe even then we won't, but it'll certainly be a lot more comforting than it is right now. Because we need those kind of solutions to really represent what the tradition of our healthcare system has meant to the individuals when they don't feel well. They go to a doctor, they tend to get some type of medical therapy, and eventually they feel better. And right now, this has a natural force to it that's really not, it's tempered a little bit by some medicines. They're really trial medicines.
Yeah, and I'd say another big change we're going to see after this is the emphasis on hygiene, and I think that's going to change the way not just physicians but all of us live day to day.
It's another really great point.
Yeah, I think the handshake is dead in our society, for just one simple example. I think the other thing that frightens me as a physician is just the unknown, because it is a brand new virus. For example, we don't know if we're going to have, like we do with influenza, if we're going to have this virus kind of taper off during the warm summer months here. We don't know if it's going to be seasonal. We think it probably is, by the way, but there's just too many unknowns right now.
We're learning every day. Every day there's new information, new studies that come out, and we'll continue to learn more about this virus.
Very helpful information. Next question is, when do you expect COVID-19 to peak in central Iowa?
Kevin, you want to answer that?
Yeah, I think, so we're probably looking at, what, today we looked at probably 2 or 3 weeks. Still, I mean, a lot of the question is, you know, your assumption about how effective some of the social distancing piece has been in slowing down the spread of the virus. And, you know, it depends on, you know, that percentage effectiveness as to when we think the actual peak will come.
Yeah, I would say quick caveat, and Bob mentioned this, but just to reinforce it, it changes the models we look at, and we're all looking at multiple models every day, change every day. Kevin's right. The biggest factor seems to be how well Iowans are doing with social distancing and staying at home when at all possible. And that's the biggest factor, not only in the size of the peak, but the timing of the peak.
All right, important information to know. And as you said before, these are sort of changing models too. I think it's important for people to remember that. Bob Riley, question, are all states, including Iowa, utilizing the same models of data to determine public policy?
I'll be happy to answer that one, Jay. And I think the quick answer is we're all using multiple sets of information to derive the best public policy, not the least of which is working together across state lines with the federal government and certainly all the public health departments. So the answer is we're in this together, as the tagline says. We're learning by the day. And if we see something new on public policy, certainly we would change our position that it was beneficial. You know, there's this debate about shelter in place, and that would be the one area, I think, if you look at a map where perhaps states vary or different. But again, when you look at density of Iowa, and you look at the density of some of these other states, and then you look at the standstill studies that have been done by the cell phone companies, you find that by and large, Iowa has been pretty responsive to the isolation recommendations, which in essence have a lot to do with shelter in place as well.
Thanks for that as well, Bob. So next question is, first of all, thank you for all you're doing to prepare to care for Iowans. And we hear a lot about the shortage of supplies and ventilators across the country. Do you have any concerns locally?
Kevin?
Do you want to take it?
Yeah, I would say ventilators, as you would imagine, is one of the resources we look at several times a day. Currently, we have a great supply of ventilators in our community. I would refer back to Bob's slide where he showed that peak, and he showed the entire critical care capacity throughout the country. So just as you see in other countries, I am concerned. I am concerned there could be a time where we won't have enough ventilators. I absolutely believe there will be a time where we'll need to share ventilators, not only in Polk County, but throughout the state and throughout the country. We are working hard every day to not only make sure that our ventilators are working and as efficient as they can be, but just like every other health system and area in the country, looking to find where we can get new ventilators. there are new manufacturers now. Those ventilators aren't in the market yet, but I do worry about that for pure transparency.
And it's another reason for trying to flatten the curve is gives us some time for all these resources that we're okay right now, but we know we're going to need more. So we're gearing up on how can we obtain these resources? How can we shift resources that we have? How can we get Ford Motor Company to start making ventilators, et cetera? That is happening, and flattening that curve gives us a little bit of time.
More great information. Thanks for that. Next question is, as local businesses, what can we do to help?
Yeah. Go ahead, Kevin. You get it?
No, go ahead, Bob.
Well, I think first of all is heed the wisdom of policy, and to the extent that we can keep people socially distant, it's critical. The only way our healthcare system can be the most efficient responder to this is by reducing that transmission rate as close to 1.0. And right now it's around 3, on most studies. So as business leaders, endorse these recommendations as not being some crazy policy, but rather being really part of our healthcare delivery system. I think the second thing is the references to protective equipment and things like ventilators, oxygen support. This is an entrepreneurial community. The number of calls and emails I've received unsolicited about people who either have some ties to Central Iowa or went to Ames or has an engineering background, or has an entrepreneur in a family that wants to help. It's been incredible. And so I would say, don't ever think that the crazy idea you're thinking about is crazy. In fact, to the contrary, bring them forward. Let's keep the community close and communicating. Kevin, over to you. Sorry.
No, that's perfect. Yeah, and I think, if you've got 3D printing capabilities or you've got manufacturing capacity, don't hesitate to reach out to Bob or I, and, we can hook you up on, the patterns to make gowns or masks or face shields or whatever it might be. We would take all of that we can get. And then I think, even from, the standpoint of a recovering accountant, I would go to more of the emotional support for your, caregivers and for your hospitals. They are showing up for you every single day, and they will continue to show up for you to take care of you. I'm sure every one of you knows a physician or a nurse, or your staff know a physician or a nurse. They need your support. And so I think whatever you can do to just demonstrate, how important these people are to you, is helpful for all of us as we try to, keep them going and keep them safe, knowing that you care about them and the community cares about them is an important component as well.
But don't hug them. We need them healthy.
Exactly.
Well, that's very helpful, and to Bob and Kevin both. As you have other needs, please let us know. We can help get the word out to our business community and all of our members. And so, as this continues to evolve, please keep close contact with us, and we're happy to help get that word out there. Next question. With 74 currently hospitalized, what is your estimate of our current capacity?
Current state, we have outstanding capacity in both. I don't want to speak for Mercy, but I know they also have outstanding capacity.
I think the same, very much the same here as well. We are ready.
Yeah, I think the other thing that you have to understand is, so we are working together and with Broadlawns and with the state to, look at all different scenarios. We've talked a lot about, the modeling and how, depending on the assumptions, as they change every day, where the fat part of the likelihood is, and then where the tails are, and we're planning for the tail as well. And, if we've got to increase capacity through other means that are non-traditional, for healthcare, then we are prepared to do that in concert with Mercy One and the others in the state. And so we'll have capacity.
I think that's going to be another great case for telehealth, not just on the clinic side, but there are remote monitoring capabilities where if you are not really, really sick, I think we're going to be able to really provide a good deal of support at home, along with portable oxygen, maybe an IV, physicians that actually we're going to go back to the old days and maybe travel door to door. And with some remote monitoring skills, I think we can really help capacities in all of our hospitals by saving them for the sickest of the sick and treating a lot of patients at home, and we're ready to do that.
I think that's really important information to know, and as if we get to those points that all of us as leaders need to be able to help carry that message to our constituencies, because it is a change and we need to be leaders in times like this. Next question is realistically, this is a big picture public policy question. Realistically, how long can we expect this to stay around, where businesses will need to continue to have their workers working from home and communities using social distancing measures?
Well, the quick answer to that is if we all knew we would have our plans in place, locked down and ready to go. I think purely from a kind of a model standpoint, we know that there are references to mid to late April as the peak in this part of the country, certainly Iowa. And then there's what referred to as the tail down and maintaining the rate at a very low level after that. Jay, the numbers on that vary. I mean, some people will tell you it's 6 months, before normalcy is once again here. Some people tell you it's a 12 to 18 month period. Some people tell you it's 2 months after peak. I've seen models that say early June, we should be back a little bit more towards our normal way of living. Let me first say that I don't know that anything will ever be completely the same as it was before. I think all of us have grown to learn, unfortunately, in this kind of a situation, that there are things that we have to do differently. And perhaps that's the purpose of a virus at its deepest point, is to modify. But I think the peak itself, and when do you see restrictions released? Frankly, I don't know what that looks like from an official standpoint. I can't see much before mid-May, and that could be a generous, estimation. Kevin, Dr. Williams, what do you think about that time frame?
I would tend to think that I like your optimism. I would love it if it would be that, and I've seen the same thing. I think there's wide variation of what that might look like.
I just think there's a great unknown, and added to the unknowns about this disease, and the great unknown here is what's going to happen when we relax social distancing. And I agree with Bob. I don't think we're getting back to normal for a long time, but what happens when we approach normal, and what is this virus going to do? To quote Dr. Fauci, the virus has its own rules. So are we going to see a secondary peak? Are we going to see it get back into that exponential growth phase? Those are just questions that aren't known.
I think it just brings up a lot of questions in terms of long-term impact on, how we all do business and live moving forward. And there's a lot of philosophical questions that you guys touched on there that our society and policymakers are going to have to grapple with moving forward. Next question is, and this goes, Bob, to one of your previous points here. With healthcare stopping electives and losing half of your business, how long can the regional hospitals sustain this, and what does the long-term picture look like?
I'll start. First of all, let me put in context. We are approximately a $3 billion operation. Kevin, I want to say you're probably closer to $5 billion with your additional assets outside of Iowa. And
yeah.
When I talk about 50%, I'm talking about a large number. And those are the systems, and we represent about 70% of the delivery system in Iowa. And between the two of us, we take care of about 60 to 65% of all Iowans' healthcare. Our staying power is very strong, and I'm not concerned that we won't see through this and do well. You know, we're owned and operated by two national healthcare systems with combined assets of about $50 billion. And the areas that I'm most concerned about, and I'll turn it over to Kevin, I'm very concerned about the rural healthcare system, the small hospitals. So when we take 40 to 50% of our business away, you know, we can stand on that and we can see through that. These small rural hospitals, they were already financially fragile in the traditional way of delivering healthcare services. And that's why it was so important for our policymakers in Washington and here in the state to find a way to help sooner than later. But what we will be, I think we'll all emerge strong emotionally and with stamina to go. And I think it'll take some time to recover. So we're forecasting, Mercy One is forecasting to lose probably about $110 million in the next 3 months from this virus, whereas before, you know, we had a 3% operating margin. So that's the contrast. Jay or Kevin, over to you.
Yeah, I would agree with what you're saying. You know, I think that if you look at Mercy One and you look at UniPoint Health and, you know, our balance sheets and our, you know, where our rating sits in the industry, you know, we're some of the strongest health systems in the country financially and the most stable. And so I think from our standpoint, you know, I think the state of Iowa overall will be well positioned for the industry to come out of this well. You know, independent rurals are, you know, that's probably where the challenge is going to be, and the challenge will be liquidity and getting, you know, keeping cash and making sure that you've got the ability to maintain your business while you're taking such substantial drops in activity. I think it will, you know, likely spur further consolidation of, you know, health systems in the country, likely, as, you know, we're on the really high end of the rating scale. There's many hospitals that are throughout the country of all different shapes and sizes that will be facing liquidity pressures that, you know, are much more severe than what either Mercy One or we will face. I mean, I think it's fair to say, I think, you know, healthcare in the future is forever changed in lots of different ways. And, you know, I think for both Mercy One and us, we're focused on making sure healthcare is changed for the better. You know, take advantage of the crisis and the opportunity that it provides to you, and let's get virtual and telehealth. Let's find different ways to connect with consumers that are much more value added and satisfying for them. And we'll see positive change come out of this.
All right, we're running short on time here, but the questions are really good. I'm going to combine two questions here real quickly as sort of our last question, and then we'll do a quick wrap up here. But the question is, the two questions are, how much antibody testing is happening, and will this be available to the public soon? And then the final question is, the Surgeon General retracted his early comments on wearing face masks. What's your take on that?
I'll go ahead and take the first one. Yeah, so the traditional testing that we're doing now is a PCR testing, a polymerase chain reaction. And what that detects is viral RNA. So these viruses are replicating, and if you have active virus that's replicating, that's what you're detecting. I think with the question asked about antibodies, those are formed after you have the disease and at various different times. So it's a little. Some folks have looked at it. Are those helpful? They're probably not helpful in this acute phase. It will be interesting to see, you know, what percentage of our population develops antibodies and to what level going forward. So I'd say it's a little early. Yes, those are tests that can be done and you know, probably will be more valuable in the future, but it doesn't help treating the acute disease.
Yeah, I couldn't agree more with that. I talked to a pathologist, a physician leading our laboratory group today. She stressed that it's just like Dr. Carr said, these early antibody tests, first of all, they don't have to go through FDA regulation, and we don't think they're very valuable yet. I think there's a huge public health epidemiologic use for them in the future, just not in the acute phase.
Do you want to address the other?
Yeah, as far as face masks, I would say stay tuned. I'm not sure that the CDC is not going to come out and recommend face masks for everybody. I think I've hit this about 5 times, but it's a new disease, and really things are changing rapidly. What we have been doing at Unity Point, we have been taking donations from the public who, out of the goodness of their heart, are making face masks. We're not using them in a hospital setting and for direct caregivers, but we have been using them in other situations. I'll give you a perfect example in home care. We have some of our patients in home care that are using those masks. So if they do not protect against catching COVID, that's the big negative, but they do help spread, they help with droplet precautions and help against the spread of many other diseases. So I would say wait and see. Dr. Carr, interested in your thoughts?
I would agree. I think it is changing. I think if you make a good point, actually the cloth masks that people are making actually are do more good for, they're better on patients than they are on caregivers. If you think about it, if this is spread by coughing and sneezing, you have a mask on, that helps mask some of those droplets that could be coming out. But they don't really prevent the disease from getting into your mucous membranes if you're a receiver of the virus.
Yep. All very helpful, and I said that was my last question. If it's okay, if we just go maybe a minute or two longer, I think this is a really important question, and I promise this is the last question. As an essential service, my team is on site and at work. Any advice you could offer me to help mitigate exposure for my employees?
I'll go ahead and start. I mean, again, I think understanding how this disease is transmitted, knowing that it comes from droplets, know it comes from direct contact. I think that's just important for people to understand. And what's the best protection? It's good hand hygiene. It's good cleanliness. It's knowing that how it is transmitted. So I think people just need to be aware of that. You know, I know when my wife goes to the store, I tell her, I think you have to assume everybody has this, and I think you just keep your distance. You don't have direct contact. You know, if they've touched something, they're likely to put the virus on those surfaces. I think you just have to be smart about it. We need essential workers, but they need to understand how it's transmitted and try to protect themselves.
Yeah, somehow I got through medical school without being a germaphobe, but I got to tell you, I have washed my hands more in the past month than probably any comparable month in my entire career. In addition to what Dr. Carr said, I would say just kind of look at your work environment and look at your ability to spread people out. Can they work different shifts? Can you isolate as best you can? Can they work even if what we're doing, even if there are people in the same building, we're still holding Zoom conferences like you guys are here. We're limiting meetings to the best of our ability, even if we're all on site. So everything you can to minimize contact is what I'd be doing.
Well, thanks so much, everybody, for joining us. I am going to let Bob and Kevin both give a quick close here, but I do think it's important to, remember that during tough times, people look to leaders for reassurance and confidence and strength, resilience and calm. And I think that that's exactly what we've just witnessed here from our healthcare leaders. And just from the partnerships perspective, thank you for your leadership. And please let all of us know what we can do to continue to work together to help all of us get through this, and specifically to help both of your systems to get through this. And again, we're all in this together. And again, thanks for making time for us today. So closing remarks, and then we'll wrap this up.
Kevin, go ahead.
Yeah, I would just close with just a couple of reminders. One, just a thank you for affording us the opportunity to have this conversation today. And thank you for your continued support of the healthcare worker and the great work that they're doing today. And then just continued emphasis on help support the public policy sort of things that are out there. Stay home, keep your distance, and let's work our way through. And I would just hopefully give you comfort that your healthcare providers in this community are working working very tightly together to ensure that this community is prepared to handle whatever scenario comes our way, and we're blessed to have the opportunity to be in this field.
I would just add, thanks, Kevin. I would add, Jay, and everyone on the call, that we are designed for this. This is actually why we do what we do. And the people that are designed for it the most are the ones that will be actually taking care of the patients and their families. The doctors, the nurses, the technicians, the support team. We'll be tested. Our systems we put to the test. Our job as leaders is to make sure our systems can withstand those tests and prevail. And Kevin and Dr. Williams, Dr. Carr, and myself, and all of our teams, and at Broadlawns and at the veterans and across the state, we are building capacity should it be needed. We're not building capacity because we absolutely positively know it will be needed, but we have to be ready. We have to have cert. This is like the flood and making sure the wall continues to grow as the water comes up, as it comes up. We don't know what water level it's going to be. But we know we want to have the highest dam wall we can have. And our teams are working around the clock, 7 days a week. They don't know what day and night is, and they certainly don't know what Sunday versus Monday is. But what I do know is they know what their call is, and we're here and we're ready to go. And we want to partner with this community. We'll take all the support, but the one thing I would say is go on Facebook and just thank the health caregivers in this community, in this state, because they will be called to action every day from now for the next couple of months. And they'll be put to the test emotionally and physically. We want everybody to rally around them because that's what gets everybody through this. So thanks for doing this, Jay. Thanks to Dr. Carr. Thanks, Dr. Williams and Kevin. And we look forward to our community and us rallying together.
Thanks everybody for joining us. Bob, Kevin, Mercy, Unity Point, thank you so much for all you're doing. Thanks to all of you for your leadership out there. Please let us know what we can do to be helpful moving forward. And remember, we're stronger together. We'll get through this together. And everybody remember, DSM strong.